Hi everyone, thanks for joining us this morning for our second episode of Epworth Live. My name's Louisa and I'm here today with specialist breast cancer surgeon Dr. Chantel Thornton and breast care nurse Sarah Morrison, and we're going to be talking about all things breast health. If you have any questions throughout the video, please feel free to pop them in a comment below and we'll try to get to them this morning, or otherwise get back to you as soon as possible with a comment. And I guess I'll just start by getting you each to introduce yourselves and tell us a bit about what you do.
Thanks, Louisa. I'm Dr. Chantel Thornton. I'm a specialist breast cancer surgeon, which means that I specialise in the surgical management of breast cancer, which involves both breast conservation and also mastectomy with immediate breast reconstruction. And I also use oncoplastic techniques to reshape the breast after surgery. The breast cancer surgeon is responsible most commonly also for diagnosing breast cancer, for treating also benign breast disease, and for also leading the multidisciplinary team in the management of patients with breast cancer.
Hi Louisa, I'm Sarah, one of the breast care nurses working here at Epworth, Richmond. I job share with another breast care nurse, Victoria Bridal. We are here to support women that are diagnosed with breast cancer and support the breast surgeons as well. And we support women from diagnosis right through to survivorship, through their surgical treatment and then through their medical treatment, right through to getting them back to some form of normality after having a cancer diagnosis.
Right, so I guess I'll just start from the very beginning. What is breast cancer?
Very good question, Louisa. Breast cancer is basically the breast cell starts growing outside its normal boundaries. So normally cells in the body, if they start to grow wildly or bizarrely, there are special checkpoints or mediators that will recognise that and they'll switch off and destroy the cell. What happens in all cancers is that the individual, the patient's cell, so the breast cell, starts to grow wildly and abnormally, and those checkpoints or big brother cells that would normally be watching to turn off or switch off the abnormality in the cell don't work, and therefore the breast cell then grows abnormally. And breast cancer itself comes in a few forms, but the most common is ductal breast cancer, so it comes from the milk ducts. And then you can also have lobular breast cancer, and there are multiple other subtypes. But the most common is the ductal cells of the breast growing abnormally to produce the cancer.
Okay, and do some people have a higher risk of being diagnosed with breast cancer?
Yes, they do. So women that have a strong family history of breast cancer, and we're talking about women that have more than 3 relatives, first or second degree relatives on the same side of the family, women who have a family history of ovarian cancer, women who've had a male in their family with breast cancer, women that carry a genetic mutation or have Ashkenazi Jewish background have an increased risk. And then from a community perspective, we know that women, particularly in the postmenopausal setting that are overweight, women who have had prolonged exposure to estrogen therapy, women who may have had ionizing radiation to the breast previously, say in things like treatment of Hodgkin's lymphoma and the like. And then obviously just being female, increasing age. Mostly it's actually nothing that women have done. It's just being a woman and being in the Australian community. It's a very, very common disease.
Is there any way you can reduce your risk?
Yes, having lots of babies and having them before the age of 30, breastfeeding your children before longer than 6 months of age, exercising, regular exercise, 240 minutes a week, looking at 120 minutes of aerobic style exercise, and then the rest of that core body conditioning style exercise, reducing your alcohol consumption, increasing fresh fruit and vegetables in your diet, keeping your body weight in a healthy weight range, reducing your exposure to estrogen, so not taking hormone replacement therapy for a prolonged period of time.
Okay, so living a healthy lifestyle.
Absolutely, yeah. Mm-hmm.
So for those of you who have just tuned in, if you have any questions throughout our video, please feel free to pop them in a comment and we'll try and get to them before the end. All right, so when should you start checking your breasts?
I would suggest probably that, from a teenage girl, not so much checking your breast, but being aware of what your breasts look like, and then as you grow into a woman, it's more about just making sure that it's checking them in the mirror, looking at yourself, and taking note of any changes that might happen. Sometimes, just actually doing a breast check and feeling is not sort of really what the direction that we hope to go in. It's more about, changes and, dimpling or changes in the size or just anything different to what normally you see. So it's probably from, puberty onwards.
Okay,
Yeah.
and when you're checking your breasts yourself, you should be looking for those changes rather than...
Feeling for lumps as such. Yeah.
Okay, and what symptoms should you be looking out for, and when should you go see your doctor?
Oh, thank you, Sarah. Very delighted to see patients at any time. But normally what we're talking about is breast awareness. So we're looking, for example, a lump or thickening or change in contour, size, shape of the breast that lasts longer than a menstrual cycle. So that's exactly what Sarah's saying. It's normally being aware of the normal changes in your breast and knowing what's normal for you. And if you have a symptom like a nipple discharge, changes in the skin, so a thickening or crusting of the skin over the nipple, a nipple discharge, a lump in the breast, thickening in the breast tissue, or something that doesn't feel quite right, and that lasts for longer than one menstrual cycle and it continues to be there, then you should see your doctor. Or pain in the breast is also a very common finding, although pain in the breast is extremely uncommonly associated with breast cancer.
Okay. And how often should you have a mammogram, and what does a mammogram feel like?
Well, you should have a mammogram probably every couple of years, 2 years or biannually. A mammogram can be uncomfortable, but it's not painful. It's done through radiology, and it's a machine that you put your breast into the machine and it squashes it down so it gets a lovely picture of the breast from top to bottom and side to side, and those images are then reviewed by the radiologist, and then if there's any concerns, the GP will refer you on to a breast surgeon to review anything that may be, hopefully benign, but they take the most beautiful pictures of the inside of the breast. So it is uncomfortable, but at the same time, I think it depends on the size of your breast. I think it does make a big difference. Yeah.
And also at Epworth now we have this beautiful machine which combines tomosynthesis with the mammogram, and so it not only increases the sensitivity of the investigation but it also reduces the amount of compression required, and really that's what ladies find most uncomfortable, the compression. And now with this thing called CT tomosynthesis that we combine with a routine digital mammogram, the compression required is a lot less. And so women find it a lot less uncomfortable as there's minimal compression required. And we also get not only those 2D images of the head to toe and the side to side view that Sarah was talking about, but we also get this fabulous 3D image that goes through the breast that the radiologist can see, and to improve the sensitivity, particularly in ladies that have dense breasts. I normally recommend that women get breast imaging on a biannual basis, Sarah said, and you can start from age 40. Breast Screen Australia will allow women to enrol from age 40, but they would have to self-remind and self-refer until they turned 50. And then from 50 onwards, they would remind the patient. Now, the caveat to that is that unfortunately, Breast Screen only have digital imaging, and so it is not the I suppose most sensitive imaging. They don't have imaging with tomosynthesis unless of course a patient gets a call back, and then they'll be sent to a centre where there is tomosynthesis. So in ladies that are young, that have dense breasts or that have a strong family history, they are now being recommended to have their imaging done through the private sector.
Okay, and you mentioned dense breasts just then. What does that mean?
Yeah, so that means that the breasts are full of ducts and lobules. So I've got this lovely diagram. I love this diagram. So we've got a breast. This is Anatomy 101 for everyone. We've got ducts here, which then come into lobules and surrounding fat. So when you've got very dense breast tissue, what you have is a lot of ducts and lobules, which means that when you do the mammogram won't be very see-through. The mammogram will be very, very white. And so when we're looking for a breast cancer on mammography, we're looking for a little white dot. And so when you've got lots of ducts and lobules, it camouflages the problem and it makes it more difficult for things to be seen on imaging. Secondly, it makes it more difficult for you to examine your breast, because your breast will often feel very dense, very nodular, very lumpy. And thirdly, we know that breast density is an independent risk factor for breast cancer, not just merely due to the fact that there's a camouflage or a false negative effect with the imaging. So we always tell women and their breast density so that they can be aware that, you know, mammography is going to be more difficult, clinical exam is going to be more difficult, and they need to be obviously more vigilant in their breast imaging and breast examinations.
Okay, and how is breast cancer diagnosed?
About 50% of breast cancer actually is diagnosed through breast screen. It's totally asymptomatic. The other 50% may present with a symptom, the most common being a small lump or an area of thickening in the breast.
Okay, and how is it treated?
Treatment, well, that's actually a very good one. We'll involve Sarah there. Treatment will mainly involve the surgical side, so removal of the cancer, which will either be in its entirety, i.e. the entire breast with an immediate breast reconstruction at the lady's wish, or just a mastectomy if they don't wish to have a reconstruction up front, or removing the actual cancer with a surrounding margin of normal tissue called a lumpectomy. Whenever we do a cancer operation, we also sample the lymph nodes under the armpit, and the most commonly performed procedure now is called a sentinel lymph node biopsy, and that's really just to make sure, to determine how aggressive the cancer is and to see whether or not the cancer cells have had the ability to spread from the breast to the armpit to determine further treatment. And then further treatment will involve both chemotherapy, could involve chemotherapy, radiotherapy or drug treatment, and that's where Sarah will talk about her side of things, chemotherapy. Sarah not only works as a breast care nurse, but she also works at Epworth in the oncology ward. So she gets the added benefit that she sees the patients in the rooms with me when we diagnose the patient, when we do the little biopsy to make the diagnosis, and then she's able to follow them through their journey and support them when they go through their chemotherapy, if they need chemotherapy, because not every lady needs chemotherapy. Sarah, do you want to say something about that?
So quite often when you said about how is breast cancer diagnosed, it all starts, I guess, in this room. So when we get the images, Chantel then will, biopsy and send for more scans, and we'll do much more thorough investigations. The woman is usually, is told, of course, and then treatment options start from there. And there are many different ways. It's like a big recipe book, and it's just which recipe suits that person. And the treatment options can range from, chemotherapy, radiotherapy and hormone therapy, and now it's becoming more and more popular, the immunotherapies, which are making a lot of headway in the breast cancer sort of field. The other people that would be involved in the treatment are, where Chantel's or the surgical teams sort of end, I guess. Well, not end, but their parts sort of complete for the time being. The patients are then referred on to other specialists, mainly medical oncologists, radio oncologists, and they will take over the systemic care of the patient. So the hormone therapy, hopefully they don't have to have too much therapy afterwards, but it's one of those cancers that doesn't get treated and then finish within sort of 6 months. It can be 10 years, and then it's constant surveillance in the track. So it's a long time for women. They're not sick all that time, or they're not, often they're living a very well and healthy life, but they are, it's a chronic disease having it. So it's something that we're there for from the very start right through to the very end. And that's why when I talk about survivorship, it's about getting women back into the world. From what their normal is.
I think it's important to also touch on the fact that we have a very highly skilled multidisciplinary team, and I think it's very important for ladies to know, particularly women who might be living in rural and country areas, that it is very important that your case is discussed in a multidisciplinary team meeting. And so while I say, I diagnose the breast cancer, I take the patient to the operating theatre and, I remove the cancer, none of that is done before the case is discussed in a multidisciplinary team meeting with all of the specialists involved. So we're going off at lunchtime today to talk about our cases from last week. So we talk about the patients in the meeting. We review their pathology under the microscope with pathologists. We review all their imaging before we make any decision to operate on the patient. it's very important that everything is discussed in that team meeting, because we know that that improves and impacts on survival for patients, so that the oncologist will already know the story about the patient. They've already seen the pathology under the microscope, and then I'll say to them, look, my plan is this. I'll say, great, I'll catch up with the patient on the ward after you finished her surgery, Chantel, and then we'll take it from there, and we'll go back once we've done the operation, and again we'll review the pathology, we'll review the imaging, we'll say, okay, what did we find? Do we need to do further surgery, or do we now move on to further specialist treatment? And so that's really done as a joint with multiple specialists, and that's what really has significantly improved the survival of ladies with breast cancer. And it's international gold standard that, you know, your surgeon shouldn't be solely working alone to treat that patient's cancer. They should be working in a team type environment.
Yeah. All right. And how common is breast cancer?
Yeah, it's extremely common. The Victorian figure is about 1 in 8.
Yeah.
It's the most common cancer in females. And it's a frightening statistic, really, isn't it? 1 in 8 women at some stage in their life will get breast cancer. That 1 in 8 figure, though, really is in the ladies in their older age group, so, you know, in their 80s and the like. So women in their earlier ages do not need to feel alarmed by that, but as we said, just being breast aware is very important, and knowing your family history is important too.
Yeah.
And all the other stuff that we talk about is not rocket science. I mean, you know, the healthy lifestyle buzz is alive and, you know, important in the prevention of cancer as it is as for heart disease and other chronic illnesses.
Yeah. And what advice do you have for managing fear of cancer recurrence?
Oh, I'll hand that one over to you.
Yeah. I think one of the biggest things, and it's probably the most prominent question that I get asked as a breast care nurse from many patients years and years later after they've had their diagnosis of being treated for breast cancer, and it is a absolutely, you know, normal question, and it's a normal feeling to have. And quite often I just say to ladies, you're being constantly surveyed, so you're more aware, you're hypervigilant about your checking, and if from your diagnosis you'll be constantly checked. You'll always be checking in with your surgeon, you'll always be checking in with your oncologist. So I guess you're having that constant checkup compared to your friend that hasn't had breast cancer, who probably isn't being checked up or hasn't been as proactive as what they are. So if there's something does pop up later on, which, you know, cross our fingers and toes that doesn't happen, then we're onto it pretty early. So it's and quite often, you know, women are on hormone therapy for up to 10 years now, so they do feel like they're having a bit of an insurance policy with having that done. So it does relieve their anxiety a little bit.
About 70% of all breast cancers will have sort of receptors on them, which means that for estrogen and progesterone, which means that if we block estrogen and progesterone in the body, which is what Sarah's talking about, this hormone, it's sort of like, it's almost like an anti-hormone. It lowers the estrogen and progesterone in the body to prevent the cancer growing or recurring. And we actually sometimes advise that ladies take these anti-estrogen or estrogen lowering sort of tablets for up to 10 years. So they're taking a tablet every day to reduce their risk of recurrence. And so it's important to, you know, make ladies understand, you know, what their actual treatment is doing. And the fact is also that there are many other therapies that we have available to treat ladies with recurrent breast cancer. And, you know, we talk about breast cancer much more as a chronic disease now, because we know that it is a type of cancer that can come back 10, 15, 20 years later. But women are living long and active lives with metastatic breast cancer. And many of them will not die of breast cancer, they'll die of some other cause which is not associated with breast cancer. The second thing I should say is that, you know, for us, we're actually quite lucky because we're dealing with a cancer that has one of the highest survival rates of all cancers. So 94% of all ladies that are diagnosed with breast cancer will live a very long time and will survive of their disease. So from our perspective, you know, it makes our job quite rewarding because we get to see our patients for many, many, many years, and we give them very aggressive treatment often up front because we expect that they are going to live to their 80s, and we want to give them absolutely everything in world-class gold standard, I call it the Rolls-Royce treatment, to make sure that they are going to be alive for many, many years.
Yeah, exactly.
All right, and what would be your advice for looking after your mind, body and spirit if you're diagnosed with breast cancer?
That's a really important part of the whole breast cancer journey is looking after your mind, definitely. The mind does funny things. It can play funny tricks on people, and given a cancer diagnosis, particularly breast, it is very much hormonal driven. So, women are very, can be, very emotional based on just the fact that they've got breast cancer. So we always, highly recommend, support groups, support networks within within their families or within their group of friends. We also have a support group here at Epworth called Boob Club, which is for young women under the age of 45. Which is, actually Chantel's sort of demographic is a lot, which is where a lot of women that are can anywhere, they don't have to be Epworth patients, can join the club, and it's really, really good for them to be able to talk to each other. But there's lots and lots of support groups, and there's lots of support organisations, Think Pink, Counterpart, the Otis Foundation, who support, primarily women only with breast cancer. It's got a lot of support. It does have a lot of community support. Body definitely is about keeping fit and healthy. Exercise, as Chantel said, over 3 to 4 sessions a week. We have to think about our bones as we get older. That breast cancer can, so we have bone strength is something, so weights and, lots of meditation, yoga is also really important, and a healthy diet, making sure that we keep our, BMI down and our exercise up. But I think a lot of it is to do with having a healthy mind. I think that can make a big difference.
And what about the Epworth have a fabulous survivorship program,
yes,
which Sarah also helps to collaborate and facilitate with, and that's an incredible program after women have finished their immediate medical and surgical treatment, to help them with this exact thing, the psychosocial processes of in particular, women who have got to lose a breast, femininity, sexuality, the psychology of particularly if they haven't had children or if they've got children, fertility issues, etc. And we have dedicated psychologists that also help us, and dedicated exercise physiologists that help us with our patients, because it is a very, very stressful time. And I think it's just knowing from a woman's perspective that the support is there, and that it's not going to be forever, that they're going to be feeling like this, that they are going to get better, and that things are going to improve, but it is often quite difficult during the immediate management. So it's sort of just getting them through to get back on with their life and get back into the community doing the things that they love to do.
Yeah. All right. Well, thanks so much for joining us today, Chantel
Thank
and Sarah.
you.
And thank you so much for your insights.
Thank you.
And thanks for everyone who joined us this morning, and we'll see you next time.
Bye.
Bye.